Dr. David Gross, psychiatrist.
And I'm Dr. Andrew Rosen, psychologist. And this is Two Shrinks and a Mic. Today we're going to do part 2 of our discussion on attention and deficit disorder with hyperactivity and some of the methods that we have available to help this problem.
Well, you know, I think it's important for us to talk about the fact that this whole diagnosis is a bit controversial. One, because it's becoming more and more prevalent. More and more individuals, both young and older, are being diagnosed with it. And I think it's important to say that this is not a disease. In fact, there's some controversy in the whole field where some sectors talk about it as part of a normal variant of the human brain and just individuals who need to work harder on focus, concentration, distractibility. But it is a disorder. What that means is that there are enough commonality between individuals who have problems with distraction, focus difficulties, sometimes hyperactivity, impulsivity, that it becomes a disorder. But it's not a progressive disease, and one of the ways of looking at it is to view it as part of the neurodiverse spectrum. And I also think it's important to view that as not an indication that you're inferior or that God's light is not shining on you or that you've got some terrible disorder in your brain. It's an abnormality in the way the brain works. It's terribly important to recognize that there are positive aspects to having this type of disorder in terms of creativity and spontaneity of thinking. So we're going to talk today more and more about some of the treatment approaches, and which are important to underline and not just limited to medication, because just medication alone is not necessarily the right direction to go in. There's no silver bullet, and it requires, like in other areas of mental health, a combination of specialized talking therapy and medication.
You know, in some respects, it's evolved from the education system, the learning. You know, we used to think many years ago that there was only one way that we all learned, and that's why in school, the methods that were presented were did not consider that some people are better learners visually and other people learn better through hearing things, and other people learn better through both methods. And we've gone more sophisticated in understanding that there's no right or wrong, and it's not even an abnormality. It's just we all are different in our brains. And I know I'm a better learner when I hear things, and when I'm looking at something, it's not as good for me. And so this way we can look at attention issues and even hyperactivity issues as a continuation of that, meaning it's not so much of an abnormality as it is our attention span, in some respects, depends upon the environmental situation we're in. I suspect that some people have much better attention when they're doing something auditorily, or some people more when it comes to visual. So, and I suspect the same thing is involved with hyperactivity. There are certain situations where the hyperactivity calms down a bit, and other situations where it's more stimulated. So, again, as you were saying, David, it's not a disease. It's more of a disorder, and that's within the context of the situation that the person finds themselves in. Where in education, when we're young in school, it means one thing. Maybe later on, when we're in the job situation, it might mean something else that we're finding in terms of symptoms. But it's something that we can help. We can't fix it, but we can certainly help it. And as you just said, medicine is one way, and then there are other techniques that a person has to learn that will help them along as well.
You know, the classic definition of attention deficit hyperactivity disorder begins in childhood. It's not necessarily some things we talked about last time that develops in adult age, although there are exceptions to that rule. But nevertheless, individuals with attention deficit disorder in childhood often fall through the cracks. And those are the kids who have the inattention type of attention deficit hyperactivity disorder. They don't have hyperactivity. They're nice kids. They're obedient. They do what the teacher tells them to do. They just have terrible problems with staying on task and focusing and are easily distracted. And as a consequence of that, academically, they don't perform as well as they think they should. If they have not been diagnosed with this disorder, the net effect of that is you go through your academic experience with a lot of self-negative thoughts about your capabilities. You come up with conclusions that you're dumb, not as smart as somebody else, that school is not for you, and talk to a lot of adults who tell me that they dropped out of school only after high school, didn't even bother with college, or even dropped out of school earlier because they said school was not for me, and I never enjoyed it. And interestingly, many of these individuals will become entrepreneurs and successful business people because they use some of the positive traits of ADHD to help them in business. They're making deals, going out and getting business for their companies. But yet the negative self-image and negative self-esteem that can develop needs to be rectified because it can lead to I'm the black sheep of the family, I'm a no good Nick, et cetera. So that's one aspect of treatment that oftentimes is not focused on because frequently an individual will get to see a psychiatrist or a pediatrician when they're older, get a medication, and that solves the problem of focused concentration. It does not solve the problem of the negative self-image. I'm not smart. I don't do well in school. I shouldn't bother with school. It's not in my best interest concept, and that's best addressed by looking at some of the myths that come out of childhood ADHD.
You know, many years ago, somebody was giving an example that if you want to plant a garden, you don't make the garden grow. You provide an environment that is conducive to growth. And so if you have to take away some of the garbage that's in the garden, and you have to remove some of the rocks or the cement, and you have to allow for a certain amount of sunlight and water, then the plant starts to grow on its own. And I think it's an analogy we can apply to this thing we're talking about today, meaning when a child has attentional problems, they invariably develop ways of dealing with it that are not necessarily healthy or helpful. And so one of the things that we do with the non-medical treatment of ADHD is to identify some of the maladaptive ways that the child and the young adult has developed to cope with ADHD, some of which are helpful, but many of them are not helpful. Avoidance behavior or finding people to help them and becoming more dependent on other people to help them out with a problem, or just plain old giving up and finding other ways of getting satisfaction or pleasure. So one of the things we do with ADHD treatment, which very much you hear now ADHD coaching, is to help identify first, let's get rid of the things that you're doing that don't help and identify what they are, and let's replace some of these behaviors with behaviors that will be helpful in dealing with your ADHD. That's a big, big deal.
From a medication perspective, there really are two classes of medications. Mentioned it briefly last time, but the most common class are the psychostimulants that tend to work on dopamine and norepinephrine in the brain, two important brain chemicals. There's data suggesting that dopamine is the main one involved in attention deficit hyperactivity disorder. There's recently been some controversy over whether or not that's truly the mechanism, but that goes beyond the scope of our discussion today. But the psychostimulants consist of either the amphetamine family, examples of which are Vyvanse, Adderall, dextroamphetamine sulfate. Dextroamphetamine sulfate is the old Dexedrine, which is one of the early agents, and the Ritalin family, which is methylphenidate. There are long-acting versions of these psychostimulants and short-acting versions. They work rapidly. You can see response within a day or two, and then the goal is to adjust the dosage to an ideal dosage. And the question there is whether or not it's covering the individual's need for the whole day. When the pharmaceutical houses came out with long-acting Adderall or long-acting Concerta, for example, which are now in generic form, their advertising and marketing suggested that it would help a kid for the entire day. And frequently I hear parents tell me their child came home from school at 3 o'clock and was a terror. The hyperactivity, impulsivity resurfaced more severely, and their attention concentration, distractibility became quite prominent. And the reality is, when these medications come out of the individual system, there can be a rebound intensification of the symptoms. And oftentimes, these individuals are not given a short-acting version of the psychostimulant to extend the duration of action so that they can do their homework at home, or that they can be less impulsive and rambunctious at home. Have to be careful there, because if you give a short-acting agent too late, it's going to interfere with sleep. The other family is limited to 2 medications. Strattera or atomoxetine was the first one, and there's now another one that's only in brand form. The brand medications become problematic because more and more insurance companies are not willing to approve them, and the cost becomes too great. But the non-stimulant agents are norepinephrine reuptake inhibitors. They basically increase the level of norepinephrine in the brain, which also influences the level of dopamine. These agents can become very effective, but they require 2 things. One is that they have to be started slowly. When the Strattera first came out, the dosing recommendations got everybody to be nauseated and feel terrible. And so we had to backtrack after realizing that we were starting people on too high a dose and start it more slowly. And so it can take several weeks before a person gets up to a therapeutic dose. And unlike the psychostimulants, these agents don't work right away. Similar to antidepressants, you have to be on these agents for a week or 2 or 3 at a therapeutic dose to see the response. At the end of the day, if you can have the time to wait for this non-stimulant agent to work, it's a lot easier in many respects from a practical perspective to take them, because they're not controlled substances, which means you can call in a prescription, you can put refills on the prescription. The availability is not an issue like it is for the psychostimulants because of manufacturing issues, quotas for controlled substances, and demand. And in many respects, the concerns we had about blood pressure and pulse with the psychostimulants are not there with these agents. The problem is a lot of the individuals I see, college students or even high school students who have finals coming up, or grades are not good, or they're behind in their studies, want something that's going to kick in right away. And they can't afford to wait the 3 or 4 or 5 weeks it's going to take with the non-stimulant agents. And so oftentimes, out of practicality, starting with the psychostimulant makes the most sense. But these non-stimulants do work very well, but you have to be patient and have to give them some time. The psychostimulants require checking on blood pressure and pulse, and children getting a family history of congenital heart disease, because sadly there were a number of deaths in Canada in the beginning when Adderall first came out, and it turned out that these children who died turned out to have congenital heart problems, and it was a genetic problem. So asking those questions are important. Making sure that young adults and older adults who are on psychostimulants, when they go for their physicals, get an EKG just to be on the safe side. But generally, with careful monitoring, these agents can be very, very effective. They can be abused, and I'm sure everybody's heard horror stories of individuals who ended up using amphetamine-like agents to excess to either get high or be manic or be driven or think they could be more productive, and that's an issue as well.
Like with anything, since it's an issue for children mainly and teenagers, very often there's a kind of a bipolar response on the part of parents to the issue of ADHD and medicines, ranging from many parents want their children to be on these medicines as fast as possible because they know about them, or they've heard about these medicines and they want to get results. And then you have the other end of the spectrum where parents are very, very reluctant or against the idea of taking medicines for ADHD. And with those two extremes, we need to have a way of helping both those extremes get more into the middle when it comes to understanding what the advantages and disadvantages are. How do you address that? For instance, if there's parents who say, I don't want my kids on these medicines for whatever reasons. What would be your response, Dave?
Well, it's tough because we all think our kids are perfect, and anything that suggests that there are imperfections it cause you to wonder whether or not it reflects something about you, whether or your upbringing or the genes that you passed on to your child. And I tried again. I don't see children since I'm not a child psychiatrist, but I try to, I'd see often the parents who have kids where they're reluctant to start medications, and I say that look, it's part of abnormalities in our brains and bodies. I mean, if you have a problem with your thyroid, are you going to ignore it, or are you going to take medication for it because of it's a medical problem? And so I try to impress upon the parents often that this is a natural medical issue. It's not a disease, as I said, but it's a abnormality. And I also suggest that the medication is not a quick fix. A lot of parents will say, I want this to fix my child and have them be a superstar in school, and that's not fair. It's putting pressure on the child. That's not great, and it's also coming up with expectations that are not the best. So I tell individuals that medication's a piece of the story, but as you mentioned, ADHD coaching is the other piece because one of the big components of the abnormalities in attention deficit hyperactivity disorder is something we call executive function abnormalities that has to do with planning and prioritization and problem solving and multitasking, et cetera. You need attention concentration for all these things, but if you can't prioritize and you can't manage time and organize your time, even though you're focusing better, you're still not going to do well, whether it be at work or in your family or at school. And so the ADHD coaching is very much ignored, unfortunately. A lot of individuals I see who have been prescribed medication for ADHD are just given the medication and they're not paying any attention to the need for time management, organizational skill development, which, I hear from adults who are diagnosed for the first time and say, boy, I wish I had been on this medication and knew about this problem earlier because I really could have corrected some of the problems that I had growing up. So that, the ADHD coaching is when I get somebody like yourself to get involved so that we work as a team to really help manage all aspects of the problem.
Yeah, to some degree with just going on medicine, it reinforces the misunderstanding or the misbelief that there's something wrong with my brain in general and not something more specific. For instance, many people with ADHD have learned that they just have low intelligence or they're just not capable or they're just not smart. And one of the things we try to do right from the get-go is to help them understand, no, it's not an intelligence issue and it's not a generalized issue. There are certain aspects of learning that are easier for you and certain ones that are more difficult. So like anything, like if you go to the gym, there's certain things we like to do in the gym and other exercises we avoid for different reasons, but we avoid what's uncomfortable or what is more difficult. So we try to help that person understand, even when they're on medicine, that this is a skill building issue as well. It's not just take a pill. It's changing habits. It's reinforcing what you do well at already. And it's trying to overcome some Achilles heel that you might have in certain aspects of attention. And then applying certain techniques with that so that, for example, time management skills. Maybe it's essential that you have every day a list of things that are on your schedule, a calendar or a time checklist so that you can't get distracted and stray away from what you need to be taking care of. Because if you don't have that list, you might forget to do 2 or 3 things or don't do the 2 or 3 things that are more difficult for you and fall behind in those areas, get overwhelmed, and then just give up altogether. So time management is one very, very important skill. And you don't just develop time management out of the blue. You have to work at developing good time management skills. So that's just one example of what we talk about when we think about executive skills, the management of time, the management of everything that's on the radar screen, priorities, put out the fire closest to your feet first. There's different specific techniques that help the person organize better and not fall behind the 8 ball when it comes to different responsibilities, particularly in school. But as you see, and I see with adults, the same issues are involved. People with poor time management skills can be brilliant, but they fall behind and they end up getting into self-defeating behaviors and feeling incompetent or just never feel optimistic about their future. So skill building in these different areas that people with attentional problems typically have is essential, whether it's without medicine or with medicine. They work together.
One of the groups of attention deficit hyperactivity disorder that we need to talk about are kids who have the mixed type, meaning they have both the attention concentration problems, which can be a handicap in terms of new learning and performance in school, but the kids who have, in addition, the hyperactivity, impulsivity. These are the kids who become the class clown. They're terribly impulsive. They get sent to the principal's office, or they have a detention. They get into trouble in school for mischief. But they also tend to be, at times, adrenaline junkies. They'll be the first to climb a tree or jump off a roof. And that becomes almost their own identity. It's almost as if if you're the fastest gun in the West, you have to maintain that identity. And so it's not like you can walk around and no longer being the sharpshooter and the fastest gun. So these are kids who have to continue to be characters and comedians and fearless in activities in their childhood, but it takes a negative toll on their self-esteem and self-respect, and they begin to view themselves, as I said before, as black sheep, as outcasts, as within their families, very different than everybody else. And if they've not been diagnosed with the problem, then the parents are often frustrated with them, and if they have other siblings within the family, they view themselves as inferior or not as loved as their other siblings. And this is all aspects of the treatment afterwards that has to address this excess of baggage, as we talked before, that comes out of childhood. And so these are kids who oftentimes will get into trouble with drugs because both they want to potentiate that state, or they want to modulate it by reducing it. So alcohol, marijuana, opiates, cocaine, which is similar to the amphetamine family and psychostimulants, that can all be part of the picture. So suddenly you've got somebody with this underlying disorder who also has a substance abuse problem. I'll commonly see an adult who came to me who's had a significant cocaine problem. And if I'm suspicious that they may have had undiagnosed attention deficit hyperactivity disorder, I'll ask them, do you remember what it was like the first time that you tried cocaine? Not after you've been on it for a while, but the first time. If they tell me they felt cool, calm, and collected on it, I'll say to myself, gee, boy, that's similar to what many of the psychostimulants will do for somebody who has a hyperactivity aspect of attention deficit disorder. So that can be a clue that they had undiagnosed attention deficit hyperactivity disorder. And the cocaine was self-regulating them, because the biochemistry of cocaine in the brain is very similar to the effects of medicines like Ritalin or Adderall, the amphetamine agents or the Ritalin family. In fact, its effect upon dopamine. The problem with cocaine, cocaine would probably be the best treatment for ADHD if it lasted longer, wasn't addicting, and didn't create psychosis and mania, but more is used.
Other than that,
it's been fine. But it only lasts for a very brief period of time in influencing dopamine in the brain. And then there's a horrible crash afterwards where cocaine addicts become terribly depressed and fatigued and want to get the next dose of cocaine to counteract that. So can't ignore the need for psychotherapy and corrective talking therapy to help these individuals who have the hyperactive type.
Very often by the time these people get to see us, they don't have the diagnosis of ADHD. They carry a diagnosis of oppositional disorder, defiant disorder, and substance abuse disorder. and very often they're depressed because they're constantly running into failure situations. So they get an identity that is really the end result of having this deficit to begin with that was not really successfully addressed. Now, if we go back to maybe your generation and our generation, I'm sorry, a little denial there for a minute.
Yeah, exactly.
Our generation, we didn't have these medicines then. So, I mean, I know I must have struggled with attentional issues in certain areas of learning, and there was nothing else to do other than struggle with it. And we didn't even know what it was. It's very easy to just think like, well, we used to call them slow learners, but slow learners in certain areas and quick learners in other areas. So we have the good news now of being able to identify at a young age issues like ADHD, and we can really make a big inroad into understanding it, identifying it, and treating it. So in many cases, heads off a lot of the things like oppositional and defiant disorder and substance abuse and overall, giving up and not utilizing their overall intelligence successfully. So it's good news. As you said before, this is not all bad news, ADHD. It's good news that we can identify it and treat it and head off a lot of other problems when we don't treat it.
It's also important, I think, to recognize that in our field in mental health, there's a tendency to talk about all the horrible aspects of various mental health problems. The woe is me, you're inferior, you're not as good as everybody else. And in the area of ADHD, this is pretty controversial because there are lots of people who talk about the positive aspects of ADHD. I've seen a number of very successful individuals who have utilized their creativity, their people skills, their ability to get hyper-focused and be passionate about areas and be quite successful. So don't view it as a disability. View it as an issue to be addressed. If you have an interest in learning more about the positive aspects of ADHD and the fact that you shouldn't walk around with a negative woe is me approach, there's an interesting podcast by a young man entitled Fearless Now, where he interviews people around the world who have been successful but who have been dealing with ADHD and learning how to compensate for it. So it's called Fearless Now, and it's an interesting podcast. So in general, let's leave you with hope that the most important thing is recognizing that if there's a problem with it, you deal with it. So that if you growing up have difficulty with mathematics in school, and no matter how hard you try to work on mathematics and learning the various aspects of arithmetic and higher aspects of math, you get a tutor. You learn how to improve your brain in that area. And that's what we're talking about today in terms of ADHD, whether it be with talking therapy or with medication. We're just trying to help people reach their maximum potential and be successful. I'm Dr. David Gross, psychiatrist.
And Dr. Andrew Rosen, psychologist.
And we are at Two Shrinks and a Mic.
The Two Shrinks and a Mic podcast is for informational and entertainment purposes only. The views expressed are those of the hosts and guests and do not constitute medical, legal, or professional advice.
Please always consult a qualified healthcare provider before making any medical or wellness decisions. Our content is not a substitute for professional medical guidance, even though our mothers tell us we have the best advice possible.